morning, everyone. This is Pratima Penumarti, founder and president of Volunteering for Seniors, a 501c3 organization. Since 2021, we have been conducting VFS virtual webinars, talk shows, and conferences for senior citizens, and also keynote presentations, general sessions, and many other sessions that basically focuses on supporting health and self-care for seniors and caregivers of older adults and individuals with or without dementia across USA. Today's topic is bladder and bowel health basics, which is basically the adult and geriatric care. Incontinence, the loss of bladder control, can be an embarrassing issue, but it is also an extremely common problem among senior citizens. At least doing some research, I found that in 1 in 10 people, age 65 or older adults, they deal with incontinence. And symptoms range from mild leaking of urine to chronic uncontrollable wetting. But in today's webinar, we have Dr. Tanvi, who will be discussing about urinary incontinence, overactive bladder, and also we'll talk about different ways how to improve and how one can reverse some of the common issues. But let me first introduce you, Dr. Tanvi. Dr. Tanvi she's a physical therapist, and she specializes in pelvic health. She's also a board certified specialist in orthopedic physical therapy, pregnancy, and postpartum corrective exercise specialist with more than 10 years experience, also working as a full-time at Signature Healthcare, which is in Brockton, Massachusetts. She also has specialties, I think within the specialty of orthopedics, and she's also super specialty is her super specialty is spine. Sorry, correct me if I'm wrong, Dr. Tanvi. She also has unique privilege of getting into work with patients of all genders, and of course with bladder, bowel, and other sexual dysfunction, and empowers them to live the life of their choice. So she has a wonderful specialties, a combination of orthopedic and pelvic health. And we are very much excited to have her today because we want to listen, because she really listens and understands all her patients' story. A lot of questions for you, Dr. Tanvi. Welcome to Volunteering for Seniors talk show today.
Thank you, Pratima. Thank you for the introduction. And I'm very excited to be here talking to you about this subject, which deserves as much awareness and information as we can provide it, because this is something, pelvic health is a taboo subject, so to speak, and people do not come forward to talk about it as often as they should. And the lack of awareness that it generates can be really, can have such a profound impact on people's lives. So I'm excited to talk to you about this today and hope it helps people.
Thank you. Thank you very much. The very first question, I know it will be very close to you, is what is pelvic floor and what is pelvic floor physical therapy?
Yes, that's a great question. And that's a great one to kick off our talk with today. So I brought with me today a model of the pelvis. The pelvis is the bowl, the pelvic cavity, to which the spine attaches from the top and the hips attach to the side of each side, right? It is the container or the bowl in which many important pelvic organs sit, and I'm going to take them out one by one. We have the bladder, you have the uterus, the ovaries, and the vagina in females, the prostate in men, and the rectum and the anal opening in all genders. So this pelvic cavity is, at the bottom of it, we have all these muscles. Now, what you see here is just one layer of muscle. It has 3 layers, so it's not like just one sheet of muscle. It has 3 layers of muscle sitting on top of each other, all of which hold the organs up and serve various important functions. So that is the pelvic floor. When we talk about pelvic health, this is basically what we are treating, not just the muscles, but also the spine, the hips, and anything related to any of these organs. All of that counts as pelvic health. And pelvic floor physical therapy is the treatment of conditions involving these organs and the pelvic floor without invasive techniques such as surgery or injection. So pelvic floor therapy is usually the first line of defense when people start experiencing problems with their pelvic floor. And in a lot of cases, it is very effective, and we are able to help patients, and patients are able to avoid further, more invasive procedures like surgeries and so on. Unfortunately, not all providers refer their patients to pelvic floor physical therapy. So I tell people that you have to be strong advocates for yourself and speak up for yourself and ask for pelvic floor therapy if you have any issues going on with any of these things that I just mentioned. Pelvic floor therapy is a combination of manual therapy techniques. We have some electrical therapy techniques. We have a lot of patient education, movement-based exercises, breathing work, down training techniques, and a lot of also mindfulness meditation kind of things, because the nervous system, of course, is covered everywhere, right? The nervous system affects the functioning of all these organs. So stress, anxiety can make these issues worse. So we also have mindfulness-based exercises and techniques that we incorporate as part of pelvic floor therapy. So yes, pelvic floor therapy is more than just Kegels. A lot of people think, oh, pelvic floor therapy, they'll just ask me to do Kegels, just squeeze and relax. No, it is so much more than that.
Oh, that's wonderful. I mean, I definitely want to know now, what are the conditions that are treated with pelvic floor physical therapy?
So the list of conditions is exhaustive, and I've prepared a slide that we can attach here to kind of enlist them all. But the big three categories are anything that is bladder-based, bowel-based, and sexual dysfunction-based. So with bladder-based conditions, we talk about different kinds of incontinence. We talk about any pain or burning with urination, which mimics UTI. So a lot of times people think that they have a UTI, when in reality it is a dysfunction of one of the muscles, which is causing symptoms of burning with urination. So the dysuria that you may present with, if you have been taking antibiotics, repeated rounds, and your UTI is still not getting better, or if you feel like you have a UTI and then you go and get a culture done and nothing shows up on the culture, but you don't know what's happening, it is very likely that you have a pelvic floor muscle dysfunction that looks like a UTI, and pelvic floor therapy can help with that. So other bladder-based dysfunctions could be retention of urine. Sometimes your bladder muscles don't squeeze. This is usually neurological, so treating the spine can help with that. So these are urine-based dysfunctions. Sexual dysfunctions are usually pain with penetration or pain with deep thrusting movements. So women can either have superficial dyspareunia, which is superficial pain with penetration, or deep pain with the thrusting movement, or unfortunately, combination of both. They can have conditions that are the result of surgeries like hysterectomy, problems with pain in general. So pain around the vagina or the vulva, irrespective of what they're doing. So it's not only pain associated with sexual activity. They could just have pain from sitting too long. They could have pain if they indulge in some kind of heavy lifting. So that pelvic pain conditions. Also for men, prostate pain, right? Pain after prostatectomy when they have the surgery, usually after cancer, to have the prostate removed, that can cause a whole host of issues. So that is all covered here. And then we come to the bowel, where we usually treat constipation, fecal incontinence, and there's something called dysenergic defecation, where the person is trying to have a bowel movement, but they cannot empty their bowels because there is a loss of symphony or syncing between the pressure applied from the top and the opening from the bottom. So they are pushing from the top, but the bottom is not opening, so they cannot have a bowel movement. So when you have pressure here, they should open. That's how the body works. But sometimes this just won't open. And that's another thing that we can treat. So many conditions. I usually tell people it's hard to list everything. Like if you tell me I have fever, what could be causing my fever? Right. The list is endless, right? So I tell people it's more important to know what's normal. What should your normal temperature be? What's the normal range? If it's not between that range, there's a problem. Go see a doctor. Similarly, in pelvic floor, it's very important to know what's normal. And if things don't look like this, something is wrong and you should go see a doctor. At the end of all the slides, I have prepared a slide with a screening tool. It is a list of 10 questions. If you answer yes to more than 3 questions, you need pelvic floor physical therapy. So that's a very much simpler way of finding out whether or not you need pelvic floor therapy, right?
Mm-hmm. So that's excellent. That'll be very helpful. Dr. Tanvi, why is it important to treat bladder health, especially when it comes to seniors?
Bladder health in itself is a problematic condition, right? It's there's a lot of stigma attached to it, but there's so many secondary things that happen because of incontinence, which makes incontinence a lot worse than it seems at first sight. Mm-hmm. One of the biggest things that incontinence leads to is skin conditions, all kinds of skin infections, which can eventually result in ulcers and require wound management. If it gets infected, then you're going down this whole line of symptoms that you really don't want. It can get systemic. You can have infection inside your bloodstream, and no one wants to go down that road. So that is one thing. The other is, and we see this very often in physical therapy in general, not just pelvic floor therapy, is the incidence of falls. People having urge incontinence, which means they cannot control their bladder and they're running to the bathroom, usually at night, or especially at night, and falling and having hip problem, like fracturing their hips or hurting themselves in other ways. So falls, the incidence of falls doubles if you have incontinence. So if someone has incontinence, they might fall, say, twice a week, 4 times a year. Someone who doesn't have incontinence will only have 2 falls a year. So incontinence doubles your risk of falls. Admissions to nursing homes, it's doubled if you have incontinence. It's a huge reason for elders to be admitted to nursing homes because the caretakers cannot cope with incontinence. People get depressed, so they have this whole psychosocial reaction or response to incontinence. It's financially taxing to invest in pads. I'm not sure if insurance covers that. I bet it doesn't. So that itself is a huge toll, using pull-ups or any kind of protection pads. Some people, unfortunately, try to use less. And again, skin infections. People reduce the exercising they do because every time they go out, they're leaking. So not exercising, not going out, not walking. Again, so many problems just from that. So yeah, we need to treat incontinence.
The problem with that is that, which I have noticed because so many seniors, which I have seen, it's my parent too, is that with incontinence issues, even though when the point you mentioned, Dr. Tanvi, is about use of pads and stuff like that, there is only a certain limit where that can be helpful for them psychologically, because yes, we do provide, sometimes that's insurance gives, but most of them it doesn't provide with. But it's not the question of buying the pads and giving them, it's more, as you clearly mentioned, is about the psychological feeling, that does pull them down a lot because they think they're so dependent on something else, which they could have done very easily before, they were doing that.
Very true.
Yeah, that's
very true.
Interesting. Yeah. Another question, which is like, how does a healthy bladder work and what is normal bladder function?
Great question. So a healthy bladder will only need to void every 3 to 4 hours. So if you're finding yourself going to the bathroom less than 3 to 4 hours, if you're going every hour, every 30 minutes, you have what we call urinary urgency or frequency, urinary frequency, which means you're going too often, or some people also have the problem of nocturia, going to the bathroom more than twice a night if you're over 65. So if you are 65 years and over, going to the bathroom 2 times in one night is normal. If you're younger than 65, once is normal. So anything beyond that is called nocturia. A healthy bladder will also void without straining. So when you go and sit on the toilet, the bladder empties itself. you do not have to exert pressure or try to empty your bladder. The bladder naturally empties itself. Healthy bladder usually is a single stream. So the stream is not spraying or splitting into or more, streams. It's not deviating to one side or the other. If there's deviation to one side or the other, and if this happens frequently, it could be an indication of prolapse of pelvic organs. So something is pushing on the urethra and causing it to kink to one side. And there shouldn't be no need to run to the bathroom. A healthy bladder is able to hold urine until you are ready to go. You do not have this sense of urgency with a healthy bladder.
So that talks about healthy bladder, right? So, and then what changes in the body that prompt bladder control problems? So like, does age play a role in bladder control problems?
There's two things that change really. One is related more to habitual things and behaviors, and the other is an actual physical problem. So inside this pelvic cavity, say you have this bladder sitting here, right?
Mm-hmm.
And it empties in the urethra out here. Now this bladder is supported by two things, by the pelvic floor muscles from the bottom, and also a whole host of ligaments and fascia supported from all sides and connected to the pelvic cavity on the side. So you have, imagine your pelvic organs are a ship. You have anchors in the name of ligaments and fascia that hold it up to the side. And your pelvic floor muscles are like water holding that ship up. As you age, because the muscles get weak and all the ligaments and fascia, the connective tissue loses its stiffness and strength, the anchors get loosey-goosey, the water underneath the ship begins to dry up and the ship lowers, which means that ligaments are loose, muscles are weak, and you have more descent of pelvic organs, and that can cause the muscles to not work properly. So that's one problem as you age. It's just a physiological change in how your sphincters and muscles work. The other problem is more caused by our own behaviors and habits. If you are used to going to the bathroom every single time before you step out, just in case I need to go, let me go now. You cause this, you train your bladder to order you around. You train your bladder to be the boss. The bladder and the brain have this fine-tuned mechanism through which your brain knows when to empty the bladder. If you go when your brain really hasn't sent you that signal, just in case, it's called just in case peeing, then you get incontinence. And unfortunately, as we age, this habit just gets stronger and stronger because you're going on a long drive and you don't want to bother people to have them stop for you. So you just go just in case, and then it just becomes a thing.
Oh, that's a wonderful information. I mean, that generally happens with most of us too. So yeah,
it does.
I think, as you said, it's more like self-control, right? From beginning, if they try to teach their body, right? This is how we have to control our bladder. So it really helps as you age.
Yeah, and I think it's important for parents to know this also because, we tell our kids, use the restroom before we go out, and we think we are doing what's best for them, but it really isn't. Children have to learn to listen to their own bodies, to be in sync with their own bodies. So when they grow up to be adults, they have healthy bladders.
Perfect. Yes, very true. Very true. Another question is, what are the different types of bladder issues that older seniors or adults commonly face?
So one is stress incontinence. So they will be leaking with coughing, with sneezing, even with laughing. Yeah. If their muscles are really, really weak and their sphincters are not holding the urine, they might even leak with simple things like getting off a chair or getting off a car, because every time they get up, their bodies generate pressure, which goes down and makes the muscles not be able to hold the urine. Another thing we need to pay attention to or to teach people is to try and not hold their breath. If I'm getting up and I'm grunting and getting up, and every time I'm doing the motion, I'm generating a lot of intra-abdominal pressure, which, because my glottis is closed, has nowhere else to go. So it goes right down into my pelvic floor. So now, not only because I'm older, my muscles are weak, my connective tissues are weak, everything is weak, but now I'm generating this extra pressure from top. It's like asking somebody who is already weak to do a 100-pound squat. They can't, their bladders won't be able to hold. So stress incontinence is one thing. And the other, as we described, is urge incontinence, which is where you have frequency of urination having to go every couple hours or even every 30 minutes, 40 minutes. Urgency, they cannot hold their bladders until they make it to the bathroom. Urge incontinence, which is leakage of urine, associated with urgency. So they're almost there in the bathroom, but before they can, undress themselves, they have already leaked. Or when the car pulls in your driveway, just knowing that you'll now go to the bathroom, you leak. When you open the doors, latchkey syndrome, you put the key in the door and your brain now knows you have to go and your bladder will leak. And unfortunately, I have found that in adults, you usually have mixed incontinence. So you have stress incontinence from weakness and urge incontinence from habits. And then you have this deadly combination.
Right. That's a very important thing to know, because in general, till now, I was thinking it's mostly because of just stress. Sometimes the body's just dealing with stress of the medications or other psychological issues. But as you clearly mentioned, it's also the urge incontinence, right? It's a combination of both. Abhi, there's a one particular point, Tanvi, is that could you share some tips to maintain if suppose any senior does have bladder health issues? So what are some tips they can maintain that, and what they should do and what they should not?
So urge incontinence is the easiest to treat because it's more a behavioral thing. Mm-hmm. So when they come to physical therapy, we have to train patients with what we call urge suppression techniques. So there's different techniques that they can use to suppress the urge to go and almost retrain the brain to hold the bladder better. This consists of simple exercises, mindfulness techniques, distraction techniques that they can use to kind of get that feeling of urge to go away. Mm-hmm. And the other thing we do is strengthen the pelvic floor muscles. This is usually through what are known as Kegel exercises, which is squeezing the pelvic floor muscles. Kegels are not just squeezing. There's different kinds of Kegels. We have to train them for what their problem is. So if someone has a problem, say only with coughing, then we need to teach them quick Kegels. So your bladder should be able to hold at that very moment when you're coughing. So it's a powerful contraction, but not a sustained contraction. Versus someone who has difficulty making it to the bathroom, or when they're in line for the bathroom and they are in need of holding their bladder for a longer time, they don't need a very powerful contraction. They need a sustained contraction. So depending on what the patient's circumstances are, we teach them their own unique kind of Kegel. We then layer the Kegel with more functional exercises. So it's never just a Kegel. The Kegel is always combined with either a change in position or a change in function or a change in movement. Mm-hmm. And the last, but most importantly, we teach them the pressure management techniques, not holding their breath, exhaling when they do a Kegel. The combination of breath and pelvic floor coordination, along with strength, serves them best.
Oh, that's excellent. This really answers a lot of questions. And Dr. Tanvi, coming now to the bowel part, there's bowel issues which we find in some of the seniors. Does it cause bladder issues, or what is the connection between both of them?
Right. So the connection is as strong as it can really get. First of all, because of the vicinity of the organs, right? So if you're looking at a person standing sideways and this is their front and this is their back, you have the bladder in the front, and in females, you have the vagina here and the rectum at the back. In males, you'll just have the bladder and the urethra and the rectum at the back. So everything is so closely connected that any problem in one area will affect the other. The most common reason for people with bowel issues like constipation is that with constipation, they're straining so much to move their bowels that all that straining puts so much stress on the pelvic floor muscles that the muscles get weak. And because the muscles cover everything, right? So if you're straining to have a bowel movement here, you see how all these muscles go all around. So eventually, weakness of these muscles is going to cause leaking here because everything is connected. Especially if you see from the inside, you see how all the muscles go around and they're all one unit. They function as one unit. So that is one thing. The second thing is straining when you're constipated will also put pressure on the vagina and can cause issues of pelvic organ prolapse. So your vaginal wall has the bladder and the urethra in the front and the rectum in the back. So if I am constipated and pushing all the time, I can cause weakness in this part of the vagina and cause prolapse of the pelvic organ. So if I'm looking at my vagina from the bottom, I will see something is bulging here. It's not the vagina itself that's bulging out. It's that rectum pushing on the vaginal wall that is making that bulge here. Then I can eventually feel from the bottom. So if women may complain of their tissues coming out from the vagina, this is usually a result of straining. And it could be either coming from the back wall, a rectocele, or it could be coming from the front wall, a urethrocoele or a cystocele, which is prolapse of either the urethra or the bladder. And straining is a very big contributor to pelvic organ prolapse. And this is how constipation is connected to all these pelvic floor issues.
Wow. So much interesting points. Thank you, Dr. Tanvi. What would be some ways in which one can maintain the optimal bowel health?
So there's many ways. First, we'll just go over what normal bowel physiology is, right? There's something called a colorectal urge. So if you are regular with your bowel movements, you would have noticed that every morning or whenever it is your time, you have this urge to go. And your body actually tells you, okay, and that's, you have this awareness of this need to move your bowels.
Right.
This is called a colorectal urge, where your colon is going through a peristaltic wave of motion and makes things go along. And it's telling you, okay, we are full here and we need to go and we need to empty. Not listening to the colorectal urge can have huge consequences. So if you have the urge to go, and if for any reason you delay it, you lose that urge, and then your body will not volunteer to move the bowels. So now you'll have to force it to move, right? When you have the urge, your body is already trying to help you to empty your bowels. So all you have to do is go and sit on the toilet, and it's already generating that pressure for you so it can empty. And then your pelvic floor muscles relax and we have a bowel movement. When you strain your body to go, that peristalsis or that wave of motion is not happening from the top. And then you have to force things to move out. So listening to your colorectal urge, going to the bathroom when you have a need to go is very, very critical, very important. Enough fiber in your food. This is in the form of fruits, vegetables, both cooked and uncooked, eating whole grains, legumes, everything that is considered healthy by common sense is good for your bowels, good for your gut health. There's an interesting concept here in the West called a squatty potty. So squatty potty is a step-like thing that you put around the toilet so you can put your feet up on it. So your knees are now higher than your hips. And what this does is at the end of your rectum, so where your rectum meets your anal opening, you have a muscle. It's called the puborectalis. The puborectalis is a sling-like muscle. This muscle needs to relax so that this angle becomes like this, and things can come out more easily. When you use a squatty potty and make your knees move higher than your hips, it helps in relaxation of this muscle. So that angle now goes like this, and we can have a bowel movement, which is why in places where we have potties on the ground, like my grandparents had back in India, people rarely had problems with constipation because that's how we are supposed to have a bowel movement. That's nature's way of emptying your bowels.
Correct.
Like if you see like animals, if you have a dog at home, a dog will always squat. No one taught it to squat, but that's the natural way of things to move. So a squatty potty is a great idea if you have the Western toilet to help you with bowel movements. And physical activity, having some kind of exercise in your daily life. 30 minutes of physical activity as recommended by the World Health Organization is good for so many reasons, including bowel movement. So these are some of the things we can do in order for us to have healthy bowels.
True. I think the squatty potty thing, Dr. Tanvi, what you're mentioning, though it is there a lot even now in South Asian countries, just like in India, Korea, or anywhere that, anyway, South Asia. I did find that issues, they're pretty good, but never ever we heard like, people having, most of the seniors who have mostly they're having the sort of health issues, they're having handicap issues. I didn't understand. I mean, I don't know how they used to, like now here, they have all sorts of gadgets, like I have for my father, there's a special type of sitting arrangement and everything in the bathroom, for him. But just going back to those places where they just use the squatty potty type of stuff, I don't know how they had managed if they were handicapped.
Yeah.
It was always a big question for me, how they were taking care. Forget not only just seniors, but also people with handicap.
Yeah.
Biggest.
I think this is where best of both worlds kind of comes in, when you have a squatty potty and a grab bar, then you have like best of both worlds.
Absolutely. Yeah, it's really helping, people, at least the seniors here I have seen, it's really helping them a lot. This is a wonderful question because I know that you are working with all genders. So, it's definitely not just female, but male, and also with, you also work with the LGBTQ community and others. So is there any particular gender that is associated, or that particular gender associated difference in pelvic health issues? And what do you see, or what do you think are, some of the common conditions that are very unique when it comes to male or female, or, any other gender? So could you please elaborate more on that?
So incontinence is usually observed in all genders, but usually more in older adults. So that's an age-based thing, not a gender-based thing, really, especially stress incontinence, which is weakness of muscles. So anyone 60 years and over is likely to have incontinence issues. Females may be a little more likely purely from anatomical reasons, because males have a longer urethra. It goes through several structures before it comes out. Females have a shorter urethra, so they're more likely to leak. But other than that, females are more likely to have issues of pelvic organ prolapse, again, because of reasons ranging from childbirth to hormonal changes as they go through menopause, the quality of tissue changes, the supportive structures change as they age. So women have more pelvic organ prolapse. Men, I've never seen a man with a pelvic organ prolapse or a man whose bladder is descending or anything like that. Men, on the other hand, tend to have all issues related with prostate and prostate pain.
Yeah.
So prostatitis or pain or dysfunctions of other kinds after having prostate surgeries. With the LGBTQ community, transgender individuals, especially if they have undergone any gender affirming surgeries, so from male to female or female to male, then they need pelvic floor therapy both before and after their surgeries in order to help their body adapt to those changes.
So I think, do you want to talk anything related about menopause?
Yes. So
I mean, anything more pelvic issues or anything prolapse in women that time?
So with menopause, there's two things really that stand out. One is the vaginal dryness leads to irritation of the vagina, especially when sexual activity is involved. So some women do benefit from special kinds of lubricants. Pelvic floor therapy is great because when you work those muscles around the vagina, it helps in increasing circulation there. It helps in increasing the quality of tissues, really. So women are shocked to hear that just doing Kegels will improve their sex life after menopause, but it does. We also train people to do all kinds of stretching exercises and such, because as you go through menopause, your bone quality changes, your muscles get stiffer. So doing any kind of exercise that improves the flexibility of your spine, of your hips, will help with your symptoms. And doing strength training helps with quality of bones. So if someone comes with me with menopause, I don't just treat their pelvic related issues. We treat all the other conditions that are associated with menopause, namely joint stiffness, bone health, and so on.
Oh, okay, that's wonderful information. Dr. Tanvi, when is the correct time or the right time for any senior to seek medical help? And which healthcare providers or professionals they are the best one, or equipped to manage pelvic health conditions, mostly in seniors?
As soon as you can see a doctor, now is the best time. I tell them, don't wait. Now is the best time. The earlier you seek treatment, you nip things in the bud, you're more likely to avoid other complications that might arise from it. And a lot of there's so many providers that will kind of address this issue, because you see how all these different structures are associated with. So you could see a urologist, you could be seeing just your primary care provider and talk to them. You could be seeing, say, a nurse practitioner, or if you have again, OBGYN or urogynecologist, they might help you with treatment. Any GI related issues. So we also see a lot of abdominal pain issues and things like endometriosis or polycystic ovarian syndrome, even fibroids, uterine fibroids, ovarian cysts. So all these things fall under pelvic pain. So we get referrals from different providers, like even GI specialists or proctologists. All these people, abdominal surgeons, all these people refer to us, because anything between your umbilicus and your mid-thigh is pelvis. So if you have a problem in any of those regions, ask your doctor for pelvic floor physical therapy reference. We can help you.
That's amazing. Thank you so much. That really, I hope it's helping all the viewers who will be watching this. And when is the right time for any senior to basically, that's the thing which we are sorry. And if someone comes, say, for pelvic floor physical therapy, so what does that particular examination, or treatment look like? Is there any general framework that is followed?
Yes, definitely. So when you go for, I don't know if you've ever been to physical therapy, just like a regular PT,
one, yes.
Right? So you know how they do the evaluation in one visit. Your first visit is the evaluation and they look at everything. And the second visit onward, they start treatment. In pelvic floor world, your evaluation will go over 2 visits. The first visit is subjective and the second is objective, which means in the first visit, we generally talk to patients about their history, about everything that has been going on leading up to this point. We have people with things like pudendal neuralgia, which is the pudendal nerve is a nerve within the pelvis, which can cause pain, especially with sitting for a long time and so on. So we have people coming in who haven't been able to sit more than 2 hours for 15 years. So imagine the whole, list of problems they would have just from that, because you have all these complications. Similarly, if someone had undergone traumatic childbirth or any kind of childbirth issue and is now an older adult and has, say, pelvic organ prolapse or stress urinary incontinence, then I can't just start asking them about what is going on today. I need to know everything that's happened in the past that might be connected to this. So the first the first session is just taking history, and we talk about all these organs. Even if you have just a urinary problem, I need to know about constipation. I need to know if you have had a C-section. I need to know if you're going through menopause, because everything is connected. In the second visit, we do the objective exam. And here I want to bust a myth. Some people don't come to pelvic floor therapy just because they think that they will have to undergo internal work or vaginal exam or rectal exam for men. This is not always true. If a patient should choose not to have a vaginal exam, that is always on the table. I tell them, you have the option to say no. You can say, I'm not comfortable with the vaginal exam. I don't want to do it. And if at some point in future, should you change your mind, we can always do it then. We can gain a lot of information just from external palpation around the perineum, and an internal exam is not always necessary. Would an internal exam give me more answers? Yes, of course, it will give me more information. But is it the one and only thing that I need to treat you? No. Also, you say you're okay with an internal exam today. Should in 2 or 3 sessions, you want to change your mind and say, I don't want to do this anymore, that's always an option too. So everything is flexible. I believe in mutual shared decision-making. So the patient always has a voice, and the patient and I make decisions together. It's not always me telling the patient what to do. So in the internal exam, we look at all the pelvic floor organs. We look at all the muscles. The vaginal exam consists of me going at different layers inside the vaginal canal to see all the 3 layers of muscles that we talked about. We look at things on one side and then things on the other side. I look for the strength. I look for the endurance, like how long they can hold contractions. I look for any points of tenderness or pain. I see if once they contract, are they able to relax completely, or do they hold a contraction, which could result in pelvic pain. I see if coughing or lifting the head off the table causes any descent of the bladder. Am I seeing any organs move into the vagina, which is an indication of pelvic organ prolapse? I check for nerve sensitivity. Like, when you go to a regular exam, they check if your nerve sensation on both sides are symmetrical. We have to check that in the perineum too. We look for reflexes of different kinds. We look for measurements. So we have a measurement. So I measure the distance between the urethra and the anal opening. Then I make them bear down or push, and I see how much that distance changes. And if it changes more than a certain number, it tells me that there might be a tear in one of the muscles inside. So it's a very comprehensive exam. And on top of this, we also look at the hips. We also look at their ribs. We look at their spine. We look at how they're breathing. We even look at if they have neck pain or any kind of foot issues, because the body is connected and things from your head to your toe can affect your pelvis. So when you go to have a pelvic floor physical therapy exam, expect to be looked at head to toe. If your therapist is only looking at your pelvis, you have the wrong therapist.
Yeah, actually, that's a very important resource for everyone to know. That comes to the next question is to, everyone will be looking for, all the seniors. So what are the resources out there for seniors and other patients that they should be aware of? And is it okay to ask? Because I know a lot of people have that, a taboo thing, thinking, well, should I even ask? Or what is there for me to ask my physician that, to refer him or her to a pelvic PT? And, how do one senior or anyone know that he or she is a correct candidate for PPT or the pelvic physical therapy?
So there are many resources. The one most commonly used is a website called pelvicrehab.com. So if you go on the website and you enter your zip code or your town's name, it will show you a list of the pelvic floor physical therapists in that area.
Okay.
As for speaking with the doctors, the questionnaire that I talked about earlier, print that out, answer that. If you get more than 3 yeses, take that printout with you to the doctor and say, I hear that this is a valid questionnaire for me to seek pelvic floor therapy. I got more than 3 yeses. I would like to have pelvic floor therapy. Sometimes you don't need to ask. Sometimes you need to demand. Sometimes you need to speak up for yourself and say, I think I need pelvic floor PT and I would like a referral.
True, very true. Actually, Dr. Tanvi, this is a question which I know I had always in my mind and thinking about seniors. What happens if someone ignores the incontinence that happen in them, and if it is left untreated? I mean, I just wanted to know this because it's good for a lot of viewers who just want to suppress it and don't want to tell anyone.
Yeah, unfortunately, this is not one of those things that gets better with time. On the contrary, it's certainly gets worse over time. One thing can lead to problems in the vicinity in other areas. And there's so many complications that can happen. So please don't put it off. It will get worse. I can promise you. It will not get better.
Very true. And one
It
final
does.
question, because you have answered so many and so much in detail. What advice that you would love to give to our viewers, any that includes seniors and also their family caregivers who are nervous and who are embarrassed to even talk about their urinary incontinence?
I believe in what is we call in the medical term therapeutic alliance. And therapeutic alliance is alliance, almost a friendship, a kinship that every patient should feel with their provider.
Yeah.
If you don't feel comfortable talking about your health issues with your own doctor, who else are you going to talk to about? If your doctor does not provide you with that level of comfort, with that safe environment to talk about stuff in, please change your doctor. That's the first thing I'll say. You need a better doctor. If your doctor is intimidating or not listening to you, not the right doctor for you. Having said that, family can play a very important role. So taking a trusted family member along to your doctor's appointments who can bring up these delicate issues can be super helpful. So you would also feel supported by someone else being in the room with you who can kind of stand up for you or speak up for you. And the other thing is, we need to start talking about this in our own homes, in our own communities. So I'm so happy we are doing this talk today, because the more we talk about these issues, the more we are making our older adults comfortable in talking about it to their doctors. Also, we are setting a good example for our younger people, because in my home, I talk to my son about constipation. I talk to my husband about having, if he's having issues with the prostate. We need to make this part of our conversation. This is integral to our health. The pelvis is a part of our body. And if we don't talk about it, these issues just gets worse. Yeah.
Thank you. Thank you. That is so rightly said. And thank you so much, Dr. Tanvi, for sharing your time, your expertise, and advice with us. We are thankful that this will really help all our viewers. And I would request all our viewers and in future who is going to see on YouTube, people can post comments and directly if they want on YouTube, if they don't want to ask more questions. And honestly, we will be there, to keep you posted, and we'll connect you also with if Dr. Tanvi would like to answer. Putting it all together from today's talk, I would just like to put a little gist here. Dr. Tanvi, correct me if I'm wrong here, because I personally, with all, hearing all the things, I feel that incontinence and bowel issues is a symptom. It's a sign that something is wrong, and treatment will definitely improve, but may not be always, but not always cure the symptom. There are ways, as Dr. Tanvi was helping, explaining today, there are different ways to help manage incontinence. And the very first step is to recognize the symptom that something is wrong and one needs to seek help. And also it is very important to realize the psychological effects of this condition and help our aging loved ones, relative, find that help, support, and acceptance that they need. So talking about even basic conditions can be challenging for aging people and the family caretakers, and which is we all know about it. And it should not have to be, and it doesn't have to be that challenging. And again, I'll be very proudly saying here that at our organization, Volunteering for Seniors, we do provide different tools that everyone needs to talk about and deal with issues facing our loved ones. So let them grow older with dignity and full independence. So contact us today if you want to learn, of course, more about what Volunteering for Seniors does and about our webinars. And again, thank you very much, Dr. Tanvi, for being with us today. Have a wonderful
Fatima, I just wanted to end with saying that I'm so happy that you're doing this excellent work for seniors, and I truly appreciate all the hard work you put into it.
Well, thank you very much. Thank you. Have a wonderful